Hello and welcome. My name is Björn Mulder. I'm a medical doctor based in the Netherlands, and in our practice we work in the space between physiotherapy and surgery. It's called orthopedic medicine. Today I'd like to walk you through one of the treatments we use most often in our clinic, and that is high-dose PRP. If you have a joint that hurts, a tendon that won't settle, or a muscle injury that just isn't healing on its own, this talk is for you. So let's start with the basics. PRP stands for platelet-rich plasma. Here's how it works. We draw a small amount of your own blood, just a little bit, maybe more than a routine lab test, and we spin that blood in a centrifuge. So the spinning separates the different parts of the blood, and we isolate the platelets. The platelets, they are tiny cells that already live in your bloodstream. And they are the messengers, so to say, of your body. The body uses these messengers to start the healing whenever you cut yourself, you sprain something, or you pull a muscle. We concentrate those platelets and we inject them, usually under ultrasound guidance, directly into the joint, the tendon, or the muscle that needs help. What's important to remember that this isn't a foreign substance. It's completely from your own biology, from your own body. The only difference is it's much more concentrated than what happens in nature. So, what makes it high dose? Now, here is where it gets interesting. So, the biological effect of PRP depends on the platelet dose, actually delivered to the tissue. The dose of the active ingredients, so the blood platelets, is very meaningful for the outcome. So the clinical threshold for what we call high-dose PRP is more than 10 billion platelets per treatment, roughly speaking, and this is applicable to large joints. Obviously, the smaller the joint, the less it needs. But this is a new standard for, let's say, a treatment of the knee joint. And once you cross that threshold, the biological response becomes much more pronounced, which is exactly what more severe joint and tendon problems need. So in our practice, our high-dose PRP is prepared with a standardized protocol that can be fine-tuned per indication, meaning we can adjust the preparation depending on whether we're treating a knee, a tendon, or multiple areas. And we can also measure the platelet count. And we do so also consistently. So this is the most evidence-based PRP that we can prepare and deliver today. Now, I want to be clear about something. In our practice, we use both what I call the classic PRP and the high-dose PRP. Both have their place. Both are effective. And the right choice depends on you, the patients. So, on the left, the classic PRP. I've named it the classic PRP. I've done it for almost 10 years now, and this is a very well-established and time-tested form with which I have a lot of experience. And especially for the smaller joints, the wrist, the ankle, the foot, it's often the right choice. For milder injuries, early stage problems, many tendinopathies, ligament strains, and patients who respond well right from the first session. So even though the platelet count per treatment is lower than our high-dose PRP, it doesn't mean it's not clinically effective. So I will keep promoting what I call the classic PRP, and I will keep using it because it works. Now, the high-dose PRP on the right, this is what we reach for in the more demanding cases, the larger joints. For instance, the knee, the hip, shoulder. Maybe there are some degenerate changes in let's say, the shoulder tendons, maybe small tears, more advanced osteoarthritis, any long-standing tendon problems that can be very stubborn to heal with other therapies or historically with the classic PRP. So in any situation where we see that we need a stronger biological signal, so the right dose for the right problem, so to say, this is the clinical question that we have to answer together when you come in or as we are treating you. So who is this treatment for? What kind of problems can high-dose PRP actually help with? So first off, osteoarthritis of the large joint, the wear and tear of knee, hip, shoulder, elbow. The knee is by far the biggest for us. This is where the evidence also is the strongest. It's been the most researched joint to treat with PRP, I believe, and also where we see quite consistent good results. Second, chronic low back pain. It's one of my favorites, actually. The facet joints, the sacroiliac joints, and especially the ligaments. The ligaments, they love PRP. Ligaments in the lumbar spine, and it's really one of our specialties in our clinic. And third off, that any tendon problems like hip tendinopathy is a big one and often a very stubborn one to treat. Tennis elbow, padel elbow, what is the new term, I believe. Golfer's elbow. Achilles tendon is also very therapy resistant. And these things usually need the high-dose PRP because they're so difficult to treat. Acute muscle tears. Now, with a muscle tear, the rules are a bit different because sometimes we tend to use what's called the PPP, the platelet poor plasma, which is the opposite basically of PRP. So I put it in here because we treat it quite often. It's an interesting thing. We don't use the PRP only, but we also use the plasma that doesn't contain so many platelets because it does contain many other things that muscles love. So that's a bit of a separate category, but I put it in there as well. Sports injuries just in general. So the kind you've tried physiotherapy, you've rested, the problem just keeps coming back. It's not eligible for surgery and you're missing your golf rounds, you're missing your tennis tournaments, your high rocks or anything else. It all goes down the drain. So we need something usually strong. And finally, I also want to mention performance medicine. And by that I mean musicians, dancers and other performing artists. We'll come back to that one in a moment. It's a particular new interest of ours. So many patients ask me what actually happens on the day of the treatment. So let me walk you through it. So we sit down together, we look at your imaging if you have it, x-rays, MRIs, we make an ultrasound usually, we examine the joint or the tendon physically, which is extremely important, and then we talk about the options and we can then confirm if high-dose PRP is actually the right step for you. So sometimes we do it on the same day if there's time for it, or we make a new appointment. We draw some blood, of course. We prepare. You can sit comfortably. It needs a couple of minutes to prepare in the centrifuges. And this is where the magic happens, so to say. This is where the platelets are isolated and concentrated. And the last step, the last but not least, is of course the injection itself. We use some local anesthetic and it's usually done under ultrasound guidance, not always, but usually to ensure the correct location. So the PRP arrives exactly where we want it to be. And actually the last step is your recovery plan. So you'll leave with clear instructions and a rehabilitation plan. I'll usually write instructions also to a good physiotherapist because this is actually a very important step. So in total, you'll be in between 30 minutes to an hour, depending on how many injections we do and how many joints we are treating. So the recovery phase. So a 4-phase plan. After the injection, you will walk through 4 phases, and each phase has its own focus. So phase 1, the first week, this is the inflammatory phase. So your body is reacting to the platelet-rich plasma, and that reaction is exactly what we want. It kicks off the healing process. You take it easy, no anti-inflammatory medication, because anti-inflammatories, NSAIDs like ibuprofen, diclofenac, that's the Dutch name, I don't know what it is in English, or in other countries around us, but any anti-inflammatories can blunt the very response that we're trying to trigger. So plain paracetamol is fine. You know, us Dutch doctors, we love our paracetamol, so just stick to that. In phase 2, so week 1 to 3, we want to protect the joint and use it gently. We start moving the joint or the limb again, gentle ranges of motion, exercises, easy walking, some stationary bike without resistance, just to get some blood flow going. Phase 3 is what we call the reparative loading. So loading and mechanical stress is also a signal for healing. Now, the new tissue is starting to mature, and it actually needs that load to become strong. So we add progressive loading, some swimming, cycling. And phase 4 is the modeling phase. So the new tissue is now modeling to a more tougher version of itself, and this is when it becomes more, you're able to load it more too, and you can start to slowly return to sport. So the tissue is reorganizing. This is where we work with your physiotherapist on sport-specific training. And one more time, because it matters, no anti-inflammatories. I mean, if you take 1 or 2 pills, it's not going to block anything, but just no structural use of anti-inflammatories or anti-rheumatic drugs. But this is all talked about before we begin, obviously. I want to be straightforward with you, without expectations, because honest expectations is what make the difference between a happy patient and a disappointed patient. You know, the best patient is an educated patient. PRP is not a painkiller. You will not walk out of this clinic without pain, being able to return to sport the same week. It doesn't work like this. The improvements are gradual. Most patients start to notice change between 6 weeks and 12 weeks. You can feel something earlier, it can feel different earlier, definitely. But real structural improvement, it's past 6 weeks, past 12 weeks, as the tissue responds and remodels. So PRP is not a cure for severe arthritis. That's the second thing I want to reiterate, because it can reduce pain, it can improve function, it can improve inflammation. It does not regrow cartilage that's already gone. You know, if a joint is at the end of its life, we will tell you this, and we will talk about maybe other options. But having this as the correct expectation is essential. Doesn't mean it cannot work. Doesn't mean you have to live with pain the rest of your life. Doesn't mean this. All right. So, and the third, many indications respond best to more than one treatment. Often we plan a small series, so spaced a few weeks apart. It really depends from person to person, but also don't expect one magic treatment that will last you 10 years. It doesn't work like this with PRP. It's a biological. So our promise to you is simple. We will be honest about whether PRP is the right step for you, or if another treatment fits you better. So the next question, is high dose PRP right for you? In general, it's a good fit if you have persistent joint, tendon, or muscle problems. If conservative care, so physiotherapy, rest, medication, has reached its limit, and if surgery isn't indicated, or you want to delay it because of fears, maybe your situation in life doesn't allow it. There are many reasons to want to avoid or delay a surgery. Another reason, if you imagine imaging confirms that a problem that PRP can realistically solve, of course, You will also be informed of this. And of course, after this, you'll have to work for your rehabilitation. So in our practice, PRP sits within a broader staircase of treatments. So from prolotherapy on the lower steps, so the more entry-level treatment, up to the high-dose PRP and other even more advanced orthobiologic protocols for patients who need more. But we recommend the step that matches your situation the best, obviously. Why would you choose us as your clinic or your practice that gives you this service? Well, first, we have a standardized protocol. We are we follow the latest literature as much as we can, the latest trends and the latest insights that have not yet reached the articles, maybe the big articles you see in the big medical journals. That usually takes a few years before new knowledge gets filtered through. So we try to keep on the cutting edge. We usually use the ultrasound. It says echo guided. I guess it's ultrasound guided in English. So almost all the injections are done using ultrasound guided approaches. Not always. It's definitely not always necessary or even helpful. And third, we are currently our protocols are being shaped by an ongoing collaboration with Dr. Mulder in Florida. He is a recognized authority in orthobiologic and performance medicine, and hence also the performance medicine part in our practice. That's really a passion that was ignited by Dr. Podesta in us. Following his lead, we follow in this area of work. So I want to spend another moment on something, on this new branch of ours, the musician's wrist, the dancer's ankle, a runner's tendon, or a dancer's tendon. These are not ordinary complaints. Performance is very precise, and the recovery has to be just as precise. So we treat performing artists and athletes with the same standard used in top-level sports medicine: precise diagnosis, targeted injection, and a rehabilitation plan built around the specific demands of your craft. So this approach has been heavily influenced by Dr. Luca Podesta, who has his career around elite athletes and performing artists. And as I mentioned before, we maintain a very active and ongoing collaboration with him. So whether you play the piano or the violin, you dance a lot, or you compete in a sport at any level, you'll find a team here that understand what your body has to do and knows what it takes to get it right. So that's the overview. If you, after this short presentation, think that high-dose PRP might be the right step for you, even if you're not sure, come in for a consultation. Send me an email. It's on the screen on the right side in the bottom, contact at DokterMulder.nl, and doctor is written with a K because it's in Dutch. So any questions or advices I'm looking forward to. Thank you so much for watching and seeing it through all the way to the end. I look forward to meeting you in our clinic. Thank you so much.